Good afternoon. It is my pleasure to present to you Getting to Zero HIV Infections in Black Men Who Have Sex with Men, Evidence-Based Approaches, Emancipation-Based Practices, and Equity-Focused Impact. I want to thank CAHR for the invitation to present this lecture to you. Uh, I hope you find it meaningful, and I look forward to your questions at the end. My name is LaRon Nelson. I am Associate Dean for Global Health and Equity and a faculty member at Yale School of Nursing. I am also an affiliate scientist and the OHTN HIV Research Chair in Implementation Science with Black Communities at the MAP Center for Urban Health Solutions at St. Michael's Hospital, which is a part of Unity Health Toronto. I'll start off this presentation saying a little bit about how these issues, this approach to my research came to be. This is me some years ago, younger, a lot longer hair. But this was soon after I finished, I think, my graduate program to become a family nurse practitioner. And I had come across this book, Discovering the Human Connectome. It's a very important book because it talks a lot about how the brain is structured and the impact of the brain structure on the body. It was really my first serious introduction to thinking about the brain and the body, but more specifically the brain as a circuit, right? A system, interconnected system that was interdependent. Something that happened in one part of the brain would have impacts on the other part of the brain, that it was not these separate regions, although they're described in that way, but that the brain was interconnected system. And even more so, that the structure, that the brain actually governed in some ways and influenced what we did, behavior, the body. So it really got me interested in understanding both structure and complexity. And one excerpt from this book talks about this is a quote: an organism's behavioral repertoire is shaped by the numerous structural and mechanical constraints, and that the anatomical organization of the musculoskeletal system supports stability and adaptive control of bodily motion and behavior. So it was actually the very idea that what we do, what we can do, and even more importantly, the limits of what we can do, right? What we cannot do is actually influenced by the structure of our bodies. And this led me to think beyond just behavior as mechanical operations, but sort of thoughtful human behavior and what the way that structures influence what people do. You know, principally at this time, I was really working in a sexual health clinic and thinking about condom use and medication adherence when we were offering treatment for certain diagnoses. So this was my introduction to thinking about why do people do things or not do things. So I really was concerned with structure, but I also began to understand that understanding structure was not enough. It was foundational to understand the structure of people's lives or situations that led them to be a patient in the clinic sitting in front of me, but that understanding the structure was not sufficient. That it was also important to investigate questions of sort of functional patterns, behavioral patterns, and the ways in which structure influence that. So, understanding when do these patterns emerge, where do they emerge, why do they emerge when they do, And then also, how are these behavioral patterns influenced by structure? And more, maybe more importantly, influenced by my uh, disciplinary training as a registered nurse. How can we intervene to affect those behavioral patterns in service of improving health outcomes for the people that we were seeing, or that I was seeing? And so what you can see here is really the dynamic difference between what it means to understand the structure in which people live and work and enjoy themselves and each other. It tells you something, some useful information, but it is very limited. That there is more knowledge to be gleaned from, potentially used when you understand both the structure and investigate how the structure functions to produce good outcomes, to produce wellness, but also in some cases to produce illness and poor outcomes, particularly among sexual minority groups such as gay and bisexual men, or uh, black, black and brown people of color. And now I'm, really jazzed about understanding structure and function. And early on in my career, I was really interested in understanding these systems in relationship to one another and how they function in relationship to one another, in hopes that I could identify disconnections or misconnections between them and find ways to plug that or repair that in the service of improving prevention and treatment outcomes. Really thinking that cooperative functioning between various systems, uh, uh, by bringing the subsystems together into one sort of end-to-end system, and then coordinating efforts between various systems could optimize outcomes. And I was very interested in figuring out how to pursue that line of inquiry that I had just found fascinating interest in. And my first opportunity to look at this came from a project that was sponsored by Grand Challenges Canada. They just launched their Stars in Global Health program. I was one of the first grantees in that program, but it supported some research among men who have sex with men in Ghana, which is a country in the western region of Africa. And that project was really about understanding the structure and function of social networks of MSM in Ghana. Because what I hope we could do is if we could really understand how these networks were structured, and what function that structure facilitated, that in collaboration with communities, we could understand how better to develop interventions that can leverage that structure. So the paper you saw at the top is one that was published that really describes what we found there. And this paper you see now in the forefront, the plus one paper, really helped us understand that you could predict condom use for multiple sexual behaviors based on the peer social networks that men belong to. And so that the peer networks were a type of social structure that could be targeted, that could be leveraged, but also could be targeted with prevention, messaging or intervention somehow that would allow for that to diffuse to its network members, and that it might be more impactful if the interventions were focused on making impact on networks versus at the individual level, or the group level, groups of people who have no connection with each other, but who are brought into a room for group interventions. And Ghana really showed us, at least in this first study, the power of leveraging existing networks and supporting those networks to achieve prevention outcomes. Now, while this was an important achievement in understanding the structure and functions of social networks, around this time, my team and I, had also really started to take seriously and acknowledge that social networks themselves, as a structure, still existed within a larger social structure, and that the men, whether in Ghana or other places in the world, their behavior or the decisions that they made were oftentimes made in the context of structures such as healthcare environments. And so we were really trying to expand how we were thinking about this. And this was around the time that we started learning about PrEP and its impact in Black communities. And so PrEP was approved by the Food and Drug Administration in 2012. And from the beginning, really, there were signals that its impact would not be equitable across racial groups. A number of studies at the time were indicating that many Black MSM didn't even know about PrEP. One such study was done by Lisa Eaton and her team. They surveyed 436 Black MSM in Atlanta, and she found that 20% were aware of PrEP 6 months before FDA approval. And 2 years after approval, that number had climbed to only 23.5%. It was not statistically significant, so we can't be confident that it changed much at all, but the number is still less than a quarter before and after. A recent paper published in September 2019 in the Morbidity Mortality Weekly Report from the Centers for Disease Control has slightly more promising news. Data from their National HIV Behavioral Surveillance Study showed high PrEP awareness among all MSM surveyed, including Black MSM. There were, however, still racial disparities indicating that Black MSM were less likely than white MSM to have discussed PrEP with their healthcare provider and less likely to have been using PrEP. And so these data can lead us into the temptation of just focusing on only what happens in the clinical encounter where these Black men are having to make decisions about PrEP or just discuss PrEP. But given my focus and interest and structure, we really wanted to understand or need to understand what is happening in the larger context of Black men's lives. So what I will do now is talk a little bit about data from an HPTN study. HPTN is the HIV Prevention Trials Network, and this was HPTN 061. It was a study that was done in 6 cities. This was Atlanta, Boston, New York, Los Angeles, San Francisco, and Washington, D.C. The data that I will show you here will be from a subsample of people from New York City. The study was about 1,500 people. This 300 that you see represented in this chart are just the men from New York City. Again, in this analysis, we were very interested in understanding both the structure in which these men live in their community, and that is what you see represented across the top horizontal axis are economic, social, and legal hardships that are a function of the environment where people live, that are structured into the environment in which these men live in New York City. And along the vertical axis are outcomes which we're positing are partially a function of the structural factors that you see across the horizontal part of the chart. So I'll tell you along the vertical axis, CIAI is condyless insertive anal intercourse. CRAI is condyless receptive anal intercourse, having greater than 2 male sexual partners, any sexually transmitted infection at 6 months, and any sexually transmitted infection at 12 months. We'll start by looking at the prevalence of economic hardships. So the three variables we looked at for economic hardships were being unemployed, having a recent job loss, or experiencing a financial crisis. And I won't go through all of these, but you will see that among the people who reported condomless insertive anal intercourse, 77% were unemployed, 83% had a recent job loss, and about 84% had a financial crisis. If you look at receptive anal intercourse, a little more than half of those people were unemployed, about half had a recent job loss, and about half had a recent financial crisis. And among people who had greater than two male sexual partners, 78% were unemployed, 87% of those had a recent job loss, and 88% of those men experienced a financial crisis. And when we conducted bivariate analyses of these hardships against these sexual health outcomes, you can see here recent job loss was associated with condomless insertive anal intercourse. This adjusted for things like income and age, that it was about people who had recent job loss were a third more likely to report condomless insertive anal intercourse. And people who experienced, black men who experienced recent financial crisis, that was associated with having greater than two male sexual partners within the past 6 months. So having a financial crisis, you were about 2/3 more likely to report having greater than two male sexual partners in the past 6 months. Now, having multiple male sex partners is not in and of itself risk, but it is important behavior that is associated with the possibility of increased exposure to sexually transmissible infections, including HIV. Now, from the prevalence of economic hardships, we'll then go at the prevalence of legal hardships. And the variables we used to look at that were history of incarceration and recent arrests. And you can see similar patterns among the men who reported condomless insertive anal intercourse. 78% had a history of incarceration. 82% had a history of recent arrest. For condomless receptive anal intercourse, 50% of those who reported condomless intercourse through receptive means had a history of incarceration, and 64%, about 2/3, had a recent arrest. For greater than two male sex partners, people who reported that, 86% of those folks had a history of incarceration, almost 80% had a recent arrest. And for any STI symptoms at the 6-month follow-up point, history of incarceration was associated, among those who reported any STI at 6 months, about 5% had a history of incarceration, 13% recent arrest, and any STI at 12 months, that number went up to almost 10% of those men, and 15% of people who reported any STI at 12 months had a recent arrest. And so this is important, especially if we think about the time when this was happening was around the time of what was called stop and frisk in New York City. So that being a black man in New York City alone meant that you were more likely to be stopped by the police, which could influence people's likelihood of being arrested, not because they were doing anything in particular other than living as a black person in the United States or New York, but because the system was structured to intentionally stop black men, black and brown men, and that structural factor meant they would more likely be subject to arrest and possibly incarceration. And then when we think about how those structures function in terms of its impact on sexual health, we can see here in the bivariate analyses that recent convictions were associated with having any STI at 6 months follow-up. And then from legal hardships, we then look at social hardships. And the measures we looked at for that in that study were unstable housing and not having health insurance, which is a very big issue in the US, where insurance is privatized, and unless people are very, very, very poor, uh, and in some cases that doesn't even matter, but unless they're very poor, they're unlikely to be able to get public health insurance. So we see here the patterns are similar for condomless insertive anal intercourse. Over 80% had unstable housing or no health insurance. For the men who reported condomless receptive anal intercourse, half of those had unstable housing, and almost half reported no health insurance. For the men who reported having greater than 2 male sexual partners, almost all, this is 90%, had unstable housing and no health insurance. And if we go down to any STI at 12 months, the folks who had that diagnosis, 10% had unstable housing, and a little more than 10%, 12.8, had no health insurance. And again, when we look at how these structural issues impact on sexual health outcomes, between the two social hardships, the one that was significant was unstable housing, that was associated with having any STI at 12 months. So men who had unstable housing were almost twice as likely to have an STI at 12 months compared to men who did not have, or men who had stable housing. And now looking at this, now it has me thinking as we go through these structural issues of economic hardships and legal hardships and social hardships that Black MSM are experiencing, even here just in New York City. It has me rethinking my original system integration thinking, which in a way assumed only that a way to improve prevention and treatment outcomes was to facilitate cooperation between systems. But what the work in HPT 061, what it showed is that there actually are systems that are already cooperating and functioning. The issue, though, is that they are not cooperating and functioning in ways that are designed to improve the health of Black MSM, the sexual health for Black MSM. And so it forced us to reckon with what if really what we're dealing with is not just really great systems that could work better if we connected them. We were already working with systems that were connected. And so part of what we understood we were seeing was a system of anti-Black racism that was working very well in cooperation with the system of capitalism, and that these two things were actually, at least partially, if not largely, responsible for the impacts, the negative sexual health outcomes that we were seeing among Black MSM in the United States. Which leads to the question, what do we do about that? If our aim is to improve sexual health outcomes among Black MSM, to reduce rates of new HIV infections, to improve treatment adherence and viral suppression rates, if these systems, these anti-Black racism and capitalism, are perpetuating the outcomes, then we have to target those systems if we want to improve the outcomes. And that was not, it's not something we learned in nursing school, and it's not something that typically is discussed in the health sciences at the graduate and doctoral level. But it had become very clear that in order for us to make an impact, we would have to really be serious about targeting these systems in some way. We then expanded our focus on understanding health systems and why health systems, or systems in general, but health systems in particular, why they're implicated in poor rates of uh, poor sexual health outcomes among Black MSM. So, healthcare settings are social settings, they are social environments that have a structural influence on HIV prevention. The climate that's created by the people who occupy roles in those systems, in those settings, whether that is nurses or administrative professional staff or physicians or social workers, those are actors, those are agents within this environment. Those roles are structured into that health setting, and the way in which people enact those roles can have an impact on HIV outcomes, including prevention outcomes. And there's literature to support this. Some work by Sarah Calabrese found that medical students, in an experiment that she conducted, that medical students were less likely to offer PrEP for patients with the highest need. So patients who could objectively be assessed based on PrEP guidelines would be people who you would definitely want to prescribe PrEP to, that the medical students were less likely to offer PrEP to those patients. And what they found was that the students made moral evaluation of people's sexual practices, and that based on their own assessment, own moral assessment of whether or not those sexual practices uh, were moral, they made decisions about whether or not giving PrEP would be facilitating people's immoral practices, or whether PrEP was being used by good people to engage in sort of normal practices. And so this is before, without anybody, how would I say it? This is not an issue about people not being motivated for PrEP. This is an issue of people having access PrEP within a system in which the providers are evaluating your fitness, your social fitness for PrEP, not your clinical fitness for PrEP. That is a problem. That structure has an impact on prevention. In another study that Calabrese conducted, they found that I believe this was medical students were more likely to rate blacks in these scenarios that they were given. They're more likely to rate blacks as risky for condomless anal insertive sex. Uh, but what risky really translated into is their decreased willingness to prescribe PrEP. So this is similar to what I just mentioned a moment ago, that providers make moral evaluations that justify, right, that justify their decision to restrict access to things like PrEP. And that justification isn't sort of evenly distributed. That when you actually look at patterns, when you look at the patterns, the functional part of the anti-black racist system, how it functions is that it restricts, it finds ways to penalize black people by restricting their access to medication that could prevent them from acquiring an HIV infection. Another study, which was on structural competency and training among medical students, found that the students viewed structural factors, right? Same similar issue that I discussed a few slides before around hardships, that they viewed structural factors as actually personal failures and a proxy for responsibility. And that was also justification, similar justifications for why you might not be willing to provide prep for patients, or why you might not be willing to spend extra time talking to them if you think that they're poor because they aren't motivated to work, or if you think they are late because they're not responsible, not because they don't have private transportation and they have to rely on a public transit system that may often break down. So these are issues that are beyond the patient's individual interests in prevention or treatment. This is about the way that the health system is structured that reinforces anti-Blackness, and that actually has an impact on patients' ability to get equitable care, or the care that somebody who was white might receive, or somebody who was straight might expect to receive. And so you might be tempted to think that this is just happening in the United States, but it is not. And it is a similar issue. Some of these things actually show up in the Canadian system, maybe not as visible because of the way that the system actually evades collecting data on things like race, but it is here. And I'll show you an example of this. This table is showing you the results from a study that we did in Toronto. This is 24 healthcare staff occupations that represent, I shouldn't say they represent, they're drawn from 10 different healthcare agencies in Toronto. So these include nurses. There were 7 nurses, 9 physicians, 1 social worker, 1 physician assistant, and 6 non-licensed personnel. So those are multiple different people, but this could be a support worker, a community health worker, a HIV test counselor. So those individuals are grouped into the non-licensed personnel. And we asked a couple questions on a survey. The survey actually also allowed for free text qualitative input, but these were some standard items that we were interested in understanding the degree to which these impacted the provider's ability to provide decision support, specifically to Black patients. So we wanted to know, when a Black person comes into your practice and is interested to talk about PrEP, or curious or not sure, but are clearly someone who may benefit based on the clinical scenario, what are things that present a barrier to providing supportive counsel for their decision making? And it doesn't mean providing decision support so that the person uses PrEP. It is really providing decision support so that people can clarify whether or not PrEP is the thing for them. So we're interested in time, whether they had low capacity or experience working with Black patients, whether it was knowledge about PrEP, cost of medication, concern about their patient's adherence or ability to adhere, their lack of knowledge about resources for PrEP, and whether they thought they had an ability to create an environment that was safe to discuss PrEP. So if we first look at time, we will see that a barrier, at least for nurses and physicians, was time. That a barrier to providing support to Black people who might benefit from PrEP was that they didn't feel like they had enough time to do it. You will see that this was not listed as an issue for the 1 social worker, the 1 physician assistant, or the 6 non-licensed personnel. So this is an issue. Patients don't determine the time intervals by which nurses and physicians see them or take time explaining it to them, but this is structured into their experience, and these folks identified it as a barrier they experience to providing care to Black people, because the question was about your Black patients. This next item is low capacity or experience working with Black patients. So about half of the nurses, half of the physicians, and the one social worker, and a little more than half of the non-licensed personnel said that a big barrier is that they don't have a lot of experience working with Black patients and don't really have capacity to work effectively with Black patients, right? So this is an issue of the provider's capacity and their lack of experience or preparation in being able to effectively engage Black patients. But that has impacts for patient outcomes and potentially on patients' ability to get quality informed counsel about things like PrEP. But you can also imagine how this applies to other issues, health issues that patients come into the healthcare environment to have addressed in order to be met, only to be met by staff who aren't really prepared to engage them. Another question we asked was, what factors would facilitate providing decision support to Black patients? And we were interested in things like more time in the appointment, being able to establish rapport with patients, enhance their capacity for work with Black patients, patients coming in prepared with information on their risk and information on PrEP in hand, more education about PrEP for the healthcare providers for them and their teams, and the knowledge about available resources for PrEP and in how to access them. So this is information that these providers could give patients. And so as you can see, both the nurses and physicians thought that having at least half of the nurses and almost half of the physicians said that having more time in an appointment would facilitate their ability to provide decision support to Black patients. uh, None of the nurses, actually, sorry, uh, uh, the second one was enhancing capacity for work with Black patients. So 3 out of the 7 nurses said that that would be helpful. 2 out of the 9 physicians, the social worker, the one social worker thought that would be helpful, but also the majority of the non-licensed personnel really thought that having some training, some education, some skills that would enhance their capacity for working with Black patients would facilitate their ability to provide decision support. But implicit in this item, which is about facilitation, is that an admission or an acknowledgement that they don't have capacity to work well with Black patients. So this is something that they say would help, but it is evidence that this is already structured into the system because these are the folks who occupy the roles within these systems. And then uh, this one is wanting patients to come into the appointment prepared with information on their risk. So the only group that thought this would help were the physicians. It was not all of them, but 4 out of 9, but none of the other healthcare staff occupations thought that this was something that would help facilitate decision support. And uh, uh, so this is just showing that these are the physicians, at least in this example, in this study, who thought that would be useful. So just think about this for a second. This is Toronto data. This is Canadian data. Canadian service providers who have challenges in working with Black patients. And if you can think and imagine the ways in which that disadvantages those patients, that is structural, an issue that is about structure. and about how our health professions are socialized, about how they're trained to interact with Black people, and in a way that plays out in their practice. And we were fortunate that people were as forthcoming as they were. I guess the data could be much worse than what it looks like, but in such a small sample, it was still pretty stunning to see what we saw there. And so, really, what I've been doing is trying to think about how to change systems, and really have started with health systems. And much of my work is based on a theory that really talks about these three key areas, which I'll talk about for a few moments, which is how do we support the patient's autonomy, how do we support their competence, and how do we support relatedness. And these are three of self-determination theory. Self-determination theory is a theory that says humans have three basic psychological needs, and when those needs are fulfilled, that people will act in ways that promote their own health interest, right? So as I mentioned before, the central one is autonomy, and that is the need to control the course of your life. Uh, we all have that need. Our patients or our clients or our research participants, according to this theory, have the need to be autonomous, to be volitional, to not be forced to do something. And it does not mean that they cannot do things in ways that incorporate feedback from providers, information, or advice, but that they're not forced into doing anything that they don't want to do. Competence is the need to be effective in dealing with the environment, to master, achieve goals that are set, including sexual health promotion goals and life goals as well. And their relatedness, which is really often missed, but it is the need to have close, affectionate relationships with others, right? With people who are trying to offer you advice. You can imagine wanting to, or how difficult it might be to respect or accept or seriously consider advice from people who don't seem to care about you. So that's why these three things really are important, that we always support patients' autonomy, that we do things that support their ability to be effective or whatever they're trying to achieve, whether it's in a health domain or outside, and that we demonstrate that we do care about them, and not just whether or not they take a pill or show up for a test or have a particular test result, but that we also care about what's happening in the full sort of context of their lives. And this shows you the self-determination continuum. This is the continuum of motivation, from amotivation, which is not motivated at all. And behavior can occur in the context of not being motivated, right? People can be forced to behave. So that would be amotivation, not really being motivated at all. Uh, that's in the black. On the right side is in green is fully self-determined motivation. Things that people do just for the enjoyment of it. They do it for the love. Sex might be intrinsic, but things like PrEP and condom use and HIV testing generally are not intrinsically motivated. They're somewhere in this middle portion, which are the red, orange, and yellow hues. Most health-related behaviors are extrinsically motivated on various degrees that are either closer to being amotivated or externally uh, controlled towards more self-determined motivation, which is things that they figure out how to integrate in their lives, even if they're not fully integrated, that they identify that this is something important that they can do. Further down where it says introjected, which is closer to a motivation, are people who do it, but they do it out of a sense of duty, or sometimes it could be a sense of, shame. or responsibility, and the further end of that, but still extrinsically motivated, is something that's externally regulated. So people who may be doing it because they will get in trouble if they don't, or because they're offered a reward for engaging in the behavior. So whether that's PrEP use, condom use, treatment adherence to antiretrovirals, HIV testing, what have you, most of that is occurring within this middle section of extrinsic motivation. And what self-determination theory offers is that there are ways to facilitate people's movement along this continuum to the degree that their autonomy is supported, that they're not forced, that they're provided with skills and tools and resources to be confident in achieving goals, and that you demonstrate that you genuinely care about them. So we had started learning this early on, and this is a second study that was, this is again from the study we did in Ghana that was supported by Grand Challenges Canada. So this was with 137 men that were recruited from 22 social networks in Accra, Kumasi, and Takoradi. These were generally younger men. I think that's just 18 to 35, but the mean age was about 25 years old. And they were approximately equally from Accra, Kumasi, and Takoradi, but Takoradi representing a little bit less of the sample. These were men who were HIV negative or status unknown. Only one person reported being HIV, living with HIV, and this was even self-report. So there's likely some error built into that. We administered a survey in this study. One of the surveys was the Healthcare Climate Questionnaire. And this is a survey that assesses the degree to which individuals feel that their autonomy is supported by their healthcare provider, that their competence is supported, and that they have a sense of relatedness. They experience a sense of relatedness from the people who are providing them care. So we looked at these items, but particularly the Healthcare Climate Questionnaire, because it was about the environment, the structure, the social setting, the context in which these men in Ghana, in this example, go to receive care. So we're very interested in understanding how that was associated with things like condom use for various behaviors. And so if you look here, HCCQ is the Healthcare Climate Questionnaire. And the Healthcare Climate Questionnaire was associated. So this is measuring essentially the degree to which patients felt that their autonomy, that their competence, and their relatedness was supported in the environment. So higher scores on the HCCQ mean that the patients felt more autonomy and competence and relatedness with that provider. So what we found here is that the Healthcare Climate Questionnaire, autonomy supportive environments, environments that in which patients felt like they were not being controlled, were associated with increased condom use, increased odds of condom use for oral sex, for anal sex, and for vaginal sex. So this is important. Even if you look at the top of this table, STI knowledge was not associated with condom use for anal sex. HIV knowledge was not associated with condom use for anything. Sense of community was associated with about a quarter increased odds for anal sex. But the one that was most predictive was what happened, how patients feel about the place they have to go for their care. This is important. This really brings in that structural factors are playing a key part in prevention behaviors and impacts for MSM, even in Ghana. And again, these are data from the project that was supported by Grand Challenges Canada among mostly men who are not living with HIV. But we also led a project a project that I was PI on, is supported by the National Institutes of Mental Health, uh, still under the CAPA project program. But this was with 225 men who were living with HIV. Uh, Screened 244, we ended up with 225 enrolled. They were all cisgender men, age 18 or older, all Ghanaian, and recruited from Accra, Kofridia, Kumasi, and Takrady. And we were also interested in, one of the things we were interested in was uh, factors that were associated with delayed diagnosis, linkage to care, and retention in care. And so what you see here is that uh, the healthcare climate, as measured by the healthcare climate questionnaire, uh, was associated with increased odds of linkage to care among men who have sex with men in Ghana who were living with HIV. So this is just other evidence that the main factors, one of the main factors that are associated with prevention and treatment outcomes is the experience that patients have in a healthcare setting, right? A structural factor. This next study is an HIV Prevention Trials Network study. This is HPTN 073. It was a study of an intervention I developed called client-centered care coordination, and it is based on self-determination theory. As you could maybe even guess this from the title on this advertisement or the tagline, "My life, my health, my choice." And so this is in a context where men could enroll in the study and even stay in the study for 12 months and never have to take PrEP, right? Many studies, when you enroll, you have to agree to participate by, using the study drug. So this was not an efficacy test because PrEP had already been proven efficacious in the IPREC study, but this was to understand whether or not this intervention could be associated, or this approach, the client-centered care coordination approach, would be associated with PrEP uptake among Black MSM in the U.S. This was in 3 cities. This was Los Angeles, Chapel Hill, Durham, North Carolina, and Washington, D.C. And initially, there was some skepticism about whether or not this approach could work. Like, if you think black gay men are gonna use PrEP in this study, and your strategy for doing that was to tell them that they don't have to use PrEP. And the answer was yes, exactly, because in reality, they don't have to use it, and we should not be in the business of trying to force this on anybody. And that in the context of control of the healthcare providers or the system, trying to exert control over decisions of Black men, that might inspire resistance, rightly so, suspicion, rightly so, in ways that they have to then protect themselves from whatever agenda you're having, which is evidenced by wanting to push this on people and on them. And there had already been some evidence of very low uptake of PrEP among Black MSM in cities across the states. And we had hypothesized that this is because the environments where the men have to go, they are structured in ways that are anti-Black and anti-homophobic. I'm sorry, anti-gay. And if we can change that, if we can relate to people in ways that convey interest in them as a human being, as a person with culture, as a person with desires, and that we can affirm and celebrate that, and minimize the degree to which we are trying to tell them what to do with their bodies and their lives, and then provide them with information and resources that we think that Black gay men may find that they could be interested in PrEP. And so this is just a figure that shows you that during the study, there was 178 people who initiated PrEP. And we thought that, so that's 79% of the 225. So we thought that we might have high PrEP uptake, but that it would probably it might take some time to get men to take PrEP. But in reality, most of those 178 people took PrEP at the first time they were offered it, the very first time. It didn't take 3 months, it didn't take 2 months, it didn't take two. That 68% of the people who took PrEP, of the black MSM who started PrEP, started at enrollment, and that the additional 11% started at a later visit. So most people who started PrEP, most of the black MSM, took it at the first time they were offered it, right? Which flies in the face of other data that suggests that there was something about the men's disinterest in PrEP. But what this study showed is that given certain environmental conditions, the removal of certain structures or the modification or transformation of certain structures within the clinic, when those are removed, that there was no problem, no issue with PrEP uptake among black MSM in these three cities. In this next slide, what you're seeing is that at 6 months, based on 161 measurements from dried blood spots, that 64% of the participants who started PrEP met the criteria for a 90% sensitivity threshold, which meant that they took at least 4 pills per week, and that represents high adherence. And so among the men who started PrEP, most of them, not as high as we would like to see, but more than half, based on objective measurements, had high adherence. So not only will black MSM, under the right conditions, structural, environmental conditions, be willing to start PrEP, but that many of them will adhere to PrEP, will adhere to PrEP. And if you might imagine, we also did a measure of autonomy in the healthcare environment using the same healthcare climate questionnaire that we use in the two studies in Ghana. We used it here. And we also found association between the healthcare climate and PrEP adherence, and that higher scores on the healthcare climate questionnaire, which is patients' rating of how autonomy supportive, how caring, and how competent supportive the environment is, was associated with PrEP adherence at 12 months. So this is important. This is different in some ways in how we've approached care of individuals across the board. Uh, a different model that is not a health education model, right? It is not people coming in and we telling them what to do. It is about being in cooperation with them, being collaborative, being advisory, but also not being oppressive, taking an emancipatory approach to this, understanding what is it that people want, what do black MSM want, and what do we do to support that. And it is not only to be concerned with what they want from a sexual health standpoint, but it is to understand for some of these things to be achieved, uh, we have to also be committed to understanding what's happening outside the clinic context, and then be willing to figure out what do we need to do to also impact those things. So that is what I mean by an emancipatory practice in a way, which is it is a practice of freedom, uh, not just from helping patients uh, be free from illness, but freedom to live full lives. And that's not just limited to clinical situations, but also the social life experience context that happens outside the clinic. And then beyond that, it really dawned on me. I was talking to someone from UNICEF who was really sort of on me about what she felt was these little small scale projects, which are important. But she really said we have to start implementing. We have to we can't just do research to find out these new discoveries. We have to start applying these things to make serious impact. And so my work has sort of moved in that direction, informed by all that we've done so far, but really saying, what do we need to do to make impact, to take what we know and make impact, or even to be making impact as we're knowing, as we're investigating and learning. And so what you see here is just the work that we did in HB 10073. We did an implementation study across 4 cities in the state of New York. Brooklyn, we did it with Heat Clinic, which is a adolescent primary care clinic in Brooklyn, and the Brooklyn Hospital Path Clinic, Evergreen Health and Mocha, which is in Buffalo, New York, Damien Family Care Center and Pride for Youth, which are 2. One is a clinic, one is a youth center in Queens, and then Trillium Health and Mocha that are in Rochester, New York. So this is that we have to do things to scale. And this was our first attempt at saying, how do we take these interventions and not just do them in a clinic in a city, but how do we work with government partners to say, if we're going to make an impact, we have to go big or go home. Everything else is just a little test that'll give us some information, but we want to be doing this in ways that we think will bend the curve, if you will. So this next few slides, I'll talk about the ways in which we're trying to do that now. Designs are a bit more complicated and these studies are more complex, but this is where I think the field must be going, especially if we're trying to effect changes in HIV/epi with Black MSM. When we understand that the issues are multifactorial, that they are multi-level, and they involve interlocking systems that really converge to put Black gay men's life, at risk, to undermine their opportunities for effective prevention and treatment. And so I'll give you some examples of some studies that have just started, and some that are at least one that's under development. But it should give you a good sense of really where I'm going with it and where I'm trying to lead and innovate, and hopefully where many of you are starting to think and possibly starting to develop projects as well. The first study I'll talk about is a study funded by the National Institute of Mental Health. It is a clinical trial planning grant. We'll be conducting a cluster randomized trial, but it's in service of generating some data for a larger study. But the title of it is Leveraging Family-Based Assets for Black MSM and Houseball Communities. And it is done with several community partners, including House Lives Matter, the Federation of Ballroom Houses, the New York City Kiki Coalition, and the Health Education Alternatives for Teens Clinic, which is Heat Clinic, based in Brooklyn, New York. This is a very interesting project because this is a project that came out of innovations within the houseball community and trying to understand what's already there, right? What Dr. Marlon Bailey calls homegrown interventions, which is looking within communities and looking at resiliencies that are already developed and emerged, and sustaining communities and finding ways to support that, so that these are not outside interventions coming in. They may miss the mark, but really look at what people are already doing to sustain and survive and supporting that. And so we work together with these partners to develop an intervention called Our Family, Our Voices, which is a model that is based on the evidence-based intervention, Many Men, Many Voices, that Michael Roberson, principally Michael Roberson, who's a icon in the houseball community, had been facilitating for many years, and that made innovations in ways to make it more relevant to the lives of people who are part of houseball communities. What you see here is the model of how we theorized this intervention would work to affect primary outcomes, which were PrEP use, being currently on treatment, HIV testing, and care engagement. And so if you look from left to right, the main components of the intervention would be increasing HIV knowledge and self-efficacy for HIV risk reduction and healthcare seeking behavior. Healthcare seeking meaning HIV testing, for example, or linkage to care. And then skills capacity building, that those will lead to motivation and also risk reduction and healthcare seeking skills, that would be boosted by video based intervention components that could be given to people through apps or text messages over time, and that would lead to the primary outcomes. But if you see in that gray circle, this is a really important innovation, because what the house ball community understood, first of all, it is multi-level because it is not just looking at the level of the individual, but it also incorporates the family, the house family, as another level of intervention impact that together can optimize the outcomes. But in this model, it's important to recognize that this goes beyond risk reduction. And if you see that gray circle with the orange explosion, the arrow going up to that says family asset building. That is important because the problems, the issues that Black MSM face are not just about reduction of risk. um, if Even if somebody has knowledge of HIV and they have skills and they know how to use condoms, so you could essentially minimize the level of risk that people have. But what that does not account for are those other factors that are represented by that gray circle, which are the things we talked about earlier on in the presentation, right? The uh, economic hardships, the legal hardships, the social hardships. And so risk reduction does nothing to impact those things, which we know have an impact on HIV prevention outcomes and treatment outcomes among Black MSM. And so in this model, family asset building is a way to build resilience. So in addition to risk reduction, asset building helps to facilitate resilience against intersectional stigma and other hardships that Black MSM will still face even after they have optimized their risk reduction. And most models don't incorporate this. And this is what we realize. One, we have to be thinking about multi-level issues and also thinking about in our work, as we are thinking about issues within the person, affecting change within the person's own psychology or behavioral repertoire, that we have to also be concerned with the larger structures that shape and influence the behavioral repertoire, which takes us all the way back to the very first few slides uh, about the human connectome and the ways in which I described that we know that behaviors are influenced by structures. And so if we're trying to optimize outcomes based on modifying behaviors of anybody, including Black MSM, we have to be concerned with the structures because the structures are major influences on the behavior. This next slide is just to show the design very briefly. So the first aim is really to conduct some formative research to assess the different changes that need to be made to refine the intervention from the many, many, many voices to our family, our voices. And then we'll conduct a pilot cluster randomized trial with 6 house-ball families, about 100 individuals who will be randomized to either the intervention arm, 3 families to the intervention, and 3 families to the standard of care control. And we'll be looking at 3 and 6 month outcomes, which are HIV testing and PrEP use for the MSM who are not living with HIV, and care engagement and currently on HIV treatment for the men who are living with HIV. The next study that I will talk about is a study that is currently active in Ghana. As you can imagine, because of the pandemic, we've halted work on this, but this is another study that really gets at multi-level approaches and trying to impact on structural issues as well. This one is called Promoting Reductions in Intersectional Stigma, or PRISM for short. PRISM Ghana is funded by the National Institutes of Nursing Research. It's a study I'm co-leading with Dr. LaRon. So this is another example of trying to do things a little bit at scale, not fully, but really getting into how do we take these interventions and test them in the context of real world clinical practice settings so that we can be learning, but also have more potential to have impact at the same time. So our partners are listed here. Our Priorities and Rights in Sexual Health is the human rights LGBT organization in Accra. YAR, Youth Alliance for Health and Human Rights, is a human rights organization for LGBT people, principally focused on youth, and that one is based in Kumasi. Also partner with the local university and the National AIDS Control Program in Ghana Health Services, which was useful to help us getting into clinics that we may not have otherwise been able to access. So there are 3 components to this. The first one is the behavioral intervention. We're using one that's called Yansipol. Yansipol was adapted from many, many, many voices maybe 4-5 years ago, some time ago, for use in the Ghanaian cultural context. So we didn't have to retest this. We had already had evidence from many implementations in the US that it worked. There was even an implementation that was done at Black Coalition on AIDS Prevention, Black CAP, in Toronto. Maybe that was in 2010 when I first arrived here. That was led by David Lewis Pert. So that was even done in Canada. But the Ghanaian version is called Yansipol, and that will be one level intervention that is focused on increasing condom use and HIV testing at the group level. There will be some components woven into it that address intersectional stigma, and the 3 stigmas that we are looking at as intersection are sexual stigma, stigma against being a same-gender loving, a practicing or desiring person, gender non-conforming stigma, and also HIV stigma, which people experience whether or not they're actually living with HIV just based on their identities as gay men or their behaviors as men who have sex with men. The next intervention component is the peer social network intervention called Hive3. The graduate students who work with me on this were big Beyonce fans, and so this is where this idea of Hive came from. But it works because this is based on a model or concept of peer support that was developed by Cindy Lee Dennis at the University of Toronto, also at St. Michael's Hospital. which are that they cover three components: empathy, education, and empowerment. And so Hive 3 is HIV, empathy, education, and empowerment. It's a manualized intervention that has standard training components for people to ensure consistency in between the peer mentors. This is each peer mentor is able to carry may not be the right word, to provide mentoring to up to 10 clients through a cell phone mediated app. And this is designed to provide social support, to reduce social isolation, and also to reduce intersectional stigma that may be internalized, because some of the messages that the men hear or have heard through growing up or through these other environments, they have come to believe in some instances. And the third level is intersectional stigma reduction in healthcare facilities. So this is targeted for changing, again, the healthcare climate, and it addresses the stigma that happens at the intersection of HIV, homophobia, and gender nonconforming individuals. But this component is targeted to changing the attitudes, if possible, but behaviors for sure, of the people who work in healthcare facilities. This is not just targeted to licensed personnel, it's targeted to anybody who works in these facilities. And we have been fortunate through our partners to test this in 8 facilities. There's only 6 here, but that's for a fact. So there are 8 healthcare facilities in Ghana, in Kumasi and Accra, that we will be working with this study. The theory model is here. What it is showing is that what we expect to happen is that uh, at the top in the blue is the intervention that is targeted to reduce intersectional stigma at the organizational level in the healthcare setting. This is using HP Plus, which stands for Health Policy Plus, which is the work of LaRon, my co-principal investigator. And at parallel, implementing Yantapo at the interpersonal level or group level, and then Hive 3, which is designed to reduce intersectional stigma at the intrapersonal level. And that by doing these two things, reduce intersectional stigma among MSM and reducing intersectional stigma in healthcare facilities, and also increasing the autonomy supportiveness of the clients for MSM in those facilities. That if we can do those things and then facilitate an interaction, which is assigning the men in our intervention group to go to the clinics in our intervention group, that we think that will produce an effect of increased frequency of HIV testing among MSM, which is our main outcome. What you see here is just the study design. Our first aim is to just evaluate the feasibility and acceptability of this multi-component, multi-level intervention to address intersectional stigma. It has a formative phase, which is what you see at the top in blue is aim 1. And then it has a randomized controlled trial phase, which is our second aim to estimate the effect size of the intervention for scale up to a definitive trial. So in a randomized controlled trial, we will have healthcare facilities that will be non-randomly assigned to the interventional control and matched. And we will have random assignment of MSM to the intervention component or the waitlist control component. So after the men in the intervention or the experimental condition completed, those who have been in the control condition will also get an opportunity to be exposed to the intervention, because again, it's not an efficacy test. It's already been demonstrated to have improvements on condom use and HIV testing. And we'll collect data at baseline in 6 months, both at the facility level and at the level of MSM. This is the last study I'll talk about. this is really the culmination of a lot of years of work in trying to understand really what it would take and what could be possible, or maybe think beyond what is possible, uh, doing the impossible to get to zero among Black MSM in the American South, testing the efficacy of an integrated strategy. This is HPTN 096. I'm leading this with Chris Byrer and Bob Remian. We're also doing this in collaboration with community and government partners. This is not an exhaustive list, but it includes the Black AIDS Institute, Southern Black Policy and Advocacy Network, NIH, CDC, and the Health Resources and Services Administration. This is important because, again, trying to move towards equity-focused impact that that the traditional sort of discovery, smaller scale testing is still important for knowledge, but we're trying to produce knowledge and trying to curb an epidemic at the same time, which means we have to be partnered with agencies, with stakeholders that can really see the type of impact that's necessary to drive the infections down in Black communities. This won't be done by just doing things in clinics. That the issues that are driving HIV among this community is multifaceted and multi-level, and it has to be addressed in that way. And so this study is trying to is attempting to do that. This is showing the integrated intervention and how we hypothesize that they will work to produce the outcomes. The ultimate outcome is reduction in HIV incidence, and we think that will happen through increasing rates of virus suppression and increasing rates of PrEP use to reduce, so virus suppression to reduce the chance of transmissibility, and PrEP use is to reduce people's vulnerability to infection if they are exposed to HIV. And how we're producing those is through an integrated strategy that has 5 components. The first component is focused on health equity at the community level. And this is serious. This is about all those things that I showed earlier, the hardships, and saying that at the first thing we have to do is be engaged with communities in ways that will improve collective efficacy, that will support economic and capacity development within communities, in ways that will support scientific literacy and advocacy in communities and civic engagement in ways that allow them to really impact the material conditions of their lives. That will be the things, even if everything else on this list looks like it might work, the peer support, the stigma reduction, that unless we're able to support communities to be self-actualized and self-determined in what happens within their communities in ways that reflect their interests and improve their lives, everything else will have a limited impact. So we have to start there, and that is a big change. HIV world, especially in the U.S. and with Black MSM, has not really gone there. It's taken this to task. But we know that we have to do this if we're serious about making it an impact, not just doing a study. The next level of that, which is also community level, is social media influencers. So again, this is trying to influence the environment in which people understand prevention, engage and embrace prevention, but also around how society, communities embrace and understand and support and reduce stigma around Black MSM who want to be themselves, but who want to be engaged in care. And we think that these 2 components are important community components that help shape the ground for these next level interventions. This next one, intersectional stigma reduction, which is similar to what I described in PRISM, except that the stigmas that this focuses on are anti-Black racism, homophobia, and HIV stigma. And this is the first time actually that we've directly engaged in intervention component that addresses anti-Black racism. That we thought it was foundational, that you couldn't do this otherwise by just talking about reducing stigma among gay men, particularly in the South. That what it means to be a gay man and what it means to be a Black gay man gets dealt with very differently in society, but especially in healthcare facilities. There's a peer support component in this too, which is to address the interpersonal level, and also home-based HIV testing and STI screening, which is also a structural intervention which reduces the need for the clinic to be the only point of contact for HIV testing and STI screening. So people will be able to collect STI samples at home, send them into a lab for testing, and they can and follow up. They can be followed up directly from this lab component, and HIV testing, which they can get the results at home, but also a component that will allow them to be connected to care if they so choose, to be linked to care. So this integrated strategy is designed to do three immediate things, which is increase multi-level social support, to reduce multi-level intersectional stigma, so stigma both at the organizational level, community level, and individual level, and decrease structural barriers to HIV services. The structural piece being access to HIV and STI testing, access to peer support outside of the clinic context, and to be exposed to a clinic environment that is more autonomy supportive and has less stigma. That those things will increase individual level agency. And agency is different from self-efficacy. Self-efficacy is people's feeling of confidence that they can do something. Agency is also about self-efficacy, but it is also about the removal of barriers, because confidence is one thing, but there are structural barriers that can mitigate the degree to which that confidence will lead to you achieving the outcomes. And so we're trying to do both those things. And so these are examples of ways that we are thinking about how to address structures, about how to support, to be anti-oppression, to be focused on the ways in which our practice can be emancipatory, and that we are doing studies in ways that are maximally focused on achieving impact for Black MSM. I've also started to think about ways in which we could do some of this work in Canadian settings. So through the support of the Ontario HIV Treatment Network, we're already testing some models right now that we hope will lead to some evidence that will allow us to do some larger scale testing of multi-level interventions, specifically to reduce HIV incidence and improve treatment outcomes for Black MSM. In summary, I'll leave you with 4 points. Structural drivers require structural interventions, and once we have recognized, as we have, that the disproportionate impact of HIV on Black MSM around the world is the result of structural issues, it forces us to think outside of only clinical interventions to move towards structural interventions at organizational levels and policy levels within organizations, but also within governments. 2, racism is an operating system. It is not these interpersonal interactions. It is a system that is at play, that everything that is happening in the context of this system. In some ways, it's like capitalism, right? It is a system. No one other person has to act in a capitalist way at any given point in time. Everything we do is contributing to the sustainment of the capitalist system. I think we can all understand that. It's important to understand that racism is the same way. It is a system in operation, and the ways in which we construct programs, the ways in which we train providers, the ways in which we construct policies, the ways in which we enact procedure and treat patients, that is all happening within the context of a racist system. And when things don't conform in that way, much like you might find in a computer operating system, it will produce errors, right? Errors because the logic in which you might be operating does not conform or align with the racist system. So we all have to understand that, because I think the part of the reason why we're having a hard time with this is that great scientists, great practitioners cannot understand that they are also complicit, a part of the racist system, even though you could certainly understand, I believe, the ways in which we're all sort of played in a system of capitalism. Risk reduction alone is insufficient. We have to move beyond just these ideas, these narratives, these programs that are about risk reduction, that don't tend to things that help build community resilience and recognize assets within communities. Because risk reduction alone will not protect people against police violence, will not protect people against economic disenfranchisement. Those things require a different level of support and asset building that can help sustain people's lives in ways that risk reduction just does not accomplish. And we have to get out of showroom, what I'm calling showroom research, which is research that's designed to be sort of boutique, small, sit on the shelf, nice to look at and nice to talk about, but get into research that helps the rubber meet the road, that is about action, that is about change and improving the lives of Black communities, and in this context, in this presentation, improving the lives and wellness of Black MSM. So this is what I mean by what it means to be evidence-based. We don't have to always recreate the wheel. There's a lot that we know out there. We can find ways to get it implemented and for it to work. That we are emancipatory in our practices, which is reducing oppression on people, on Black MSM, tackling racism, practicing anti-racism in our science and in our healthcare delivery, and working towards impact. That's what we need to be doing in order to really see getting to zero among Black MSM. So thank you for your time and attention, and I look forward to addressing any additional questions that you may have in the few minutes we have left. Thank you.